All right. So, good morning, everyone. My talk today is going to be on physician-assisted suicide. To be honest, I didn't really have any idea what I was going to talk to you about for my senior lecture, but luckily, on my first night in Tanzania, I was woken up around 4:55 a.m. for the call to prayer by the mosque across the street from our hotel that we were staying at. And during those first 5 minutes of the call to prayer, it almost kind of became like this meditative trance-like state. And my ADHD brain went on this journey where I began to think about how religion is incredibly grounding and important to billions of people around the world, and how people really turn towards religion during times of sadness or death to try to gain meaning out of life. And then that led me to think about how often we experience and see death with the job that we have, and that we don't really take the time to process the deaths that we do see. And that might be because we're really busy, we have to go on to the next patient and treat them. But I also started to think about that there might be some historical influences that have led to a taboo society where we don't really talk about death in an open way that some other cultures do. So that led me to wanting to talk about death, and more specifically, physician-assisted suicide in the realm of medicine. So quick outline, we're going to define some terms. We're going to go through the history and cultural roots of physician-assisted suicide to understand the stigma in Western culture. We're going to look at the arguments for and against it, review the current legal status in the US and then around the world, and then wrap up with a quick case just to see how this could come to present in the ED. So what exactly is euthanasia? So the U in euthanasia is short for a Greek word that means happy, while thanasia comes from the Greek word thanatos, meaning death, and together it adds up to happy death. It's this notion behind euthanasia that we should not condemn people to a slow and painful death, but instead offer the possibility to choose to die with happiness. That is the underlying message of physician-assisted suicide. Now, euthanasia itself can be broken down into passive and active. So passive euthanasia is something that we're all familiar with, that we see frequently. That's whenever we take patients off of any kind of treatments that they need to support their life. So think pressors, antibiotics, fluids, feeding tubes, anything that they need to keep their life going. So we see this in the ICU when they become comfort care or when patients are transitioned to a hospice setting. Active euthanasia is when we actively give a life-ending medication that the physician themselves administer to end the patient's life. Now, when a physician prescribes a lethal drug and the patient themselves take it, that's what's come to be known as physician-assisted suicide. There are also all these other terms that are thrown around, medical assistance in dying, medical aid in dying, and physician-assisted death. They all mean the same thing, is helping patients, assisting them with death. And in the United States specifically, our legal term is MAiD. So when we talk about the legal aspects of this, you'll see MAiD being referenced. So how did we get to where we are today? This kind of fear, potential opposition towards death, was this always the case? So not for the Greeks and Romans. Starting far back as far back as the classical period of Greek culture in the 400s BCE and spanning into the Hellenistic age and through the Roman Republic, death during that time was seen as a natural transition of life, that individuals should focus on living a life aligned with nature and find peace with death. Greeks and Romans sought to minimize fear over death, and this was exemplified by a culture that celebrated death and even had public burials where all ages were allowed to attend to commemorate that person's passing. Furthermore, mercy killings and assisted suicides were standard practices in ancient Greek and Roman times, and even seen as an honorable choice. So great thinkers like Epicurus, Lucretius, Socrates, and the Stoic school of thought all believed that accepting death was a natural and inevitable part of life. However, things started to take a change when Christianity came into play. So starting with the Edict of Milan, which was in 313 AD by Emperor Constantine, which essentially declared Christianity as a tolerated religion, giving it freedom of expression and paving the way for its growth, we start to see a shift in Western societies. And then comes St. Augustine. He's one of the greatest fathers of the Catholic Church, wrote a book called The City of God in 426 AD. And in that book, he made Christianity's first overall condemnation of suicide. His biblical justification for condemning killing oneself was his interpretation of the commandment, thou shalt not kill. Because that commandment didn't have thy neighbor in it, then he took it to mean that this should also mean you should not kill yourself. He believed that killing oneself was going against God, as all of us are part of God's property, and only God can determine what we do with our bodies. He even quoted saying that in his book, these actions, which are killing oneself, are often praised in the books of pagans. One must accept whatever is done to you and endure it in sorrow, and have patience in your humiliation. These men were not wise in choosing death, but impatient in bearing humiliation. End quote. So these reflections of Augustine became accepted by European societies and were perpetuated by medieval authors from 500s all the way to the 1500s. Two really famous medieval authors are these two Italian monks, Gratian and St. Thomas Aquinas. So Gratian's writings, which became known as the Decretum Gratiani, it helped establish this canon law for European societies to follow. And in it, he declared that no one is allowed to kill themselves. And if they do, then they will not be allowed to receive burial commemorations in any way. And Aquinas further perpetuated this belief in his writings. And by the 13th century, it was a crime to commit suicide, which would lead to family members losing all assets and properties from that individual that ended their own life. So we can see how religion started to have a direct impact on governmental policies in Europe. And I think by now you kind of get the gist of where I'm going with this. You know, the next 500 years aren't really that different all the way to the 21st century. It continues with Western societies having a strong opposition to ending one's life. And just a quick note, to skip up to modern day, is that even today, the AMA, our largest medical community, still condemns physician-assisted suicide. And it was only in the 1980s that the Catholic Church finally lifted the prohibition on funeral rites for patients who did end their own lives. So after reading through all these historical texts, I started thinking to myself, how is this the case? I feel like a lot of the people that I know in my life are agnostic or don't really prescribe to a certain religion. Can religion have such a large influence in our society, especially here in the United States? But when I took a look at the 2023-2024 data of the religious landscape in the United States, we can clearly see that the majority of Americans still identify with a certain religion, with the majority still prescribing to some form of Christianity. And really, it was only during our lifetime that we begin to see the shift toward a secular society. So I think through all of this, the big takeaway here is that religion has had an enduring impact on Western law and our ethics. And within our lifetimes really is when we're starting to see a change towards a more secular society. And to bring the point home, if religion wasn't enough to shape our society's perception on euthanasia, the Nazi regime further tainted the concept by the atrocious acts they committed in the 1940s. So starting in 1939, there was a radical and secretive eugenics program called Action T4. And this was implemented to restore the so-called racial integrity of the German nation. It was under the direction of Dr. Karl Brandt and Philip Bohler. And the Nazi Party began euthanizing initially just disabled children and then going on to disabled adults. And by the end of this program, they had claimed almost 250,000 lives. And it wasn't just disabled individuals. They started euthanizing patients that had schizophrenia, epilepsy, dementia, those not of German or related blood, or those that had just been in an institution for 5 years, even though they had no medical conditions. So again, you can see how our history, our religion has gotten us to a state where death isn't something that we're comfortable with, talked about, and has been frowned upon. So looking into the arguments for and against physician-assisted suicide. We're going to start with those in favor of. And with the ones in favor of, there are three primary ideas that are the most encompassing. And all these three arguments of physician-assisted suicide, which we're going to talk about on the next few slides, all fall underneath this idea of utilitarianism, which is essentially a moral philosophical theory that judges the actions based on their consequences. So not necessarily whether the action is inherently good or bad, but if the end result of that action is good. So in the realm of physician-assisted suicide, if the death relieves extreme suffering and respects the person's wishes, then it can be ethically justified, even if causing one's death can be seen as bad. So the first central argument for physician-assisted suicide is the right to autonomy. Nat touched on this earlier, but it's an individual's right to make decisions about their own body and life, including the decision to end their life when facing terminal illness or unbearable suffering. Prominent thinkers like Immanuel Kant emphasize autonomy as central to human dignity and moral agency, and modern utilitarian thinkers like John Stuart Mill argue that personal liberty is paramount as long as that action doesn't harm anyone else. Even the existential thinkers like Jean-Paul Sartre and Albert Camus believe that that life has meaning through individual choice. So from all of these different philosophical standpoints, we can see that having the ability to choose one manner of the way you can choose your death is a profound act of self-definition and integrity that should be honored. And on the flip side, we're constantly respecting patients' autonomy, right? Even though we know it's not what's best for them. We have patients that we allow to try their naturopathic remedies to treat their diabetes or their hypertension, or like this cartoon shows, allow them to go unvaccinated because right to autonomy. So if we allow these actions of autonomy, then why can we not allow a patient the right to maintain control, self-respect, and a sense of purpose in their final moments, rather than being reduced to prolonged suffering, loss of bodily functions, and becoming completely dependent on others? So physician-assisted suicide, when regulated, should be seen almost as an extension of patient autonomy in healthcare, similar to the right to refuse treatment or create advance directives. Following the right to autonomy, the second argument in favor for is the death with dignity idea. And these two are essentially irrevocably intertwined with each other, because as soon as we allow a patient to have the right to autonomy, that means that they will be allowed to die with dignity if that's the path that they choose to do so. This death with dignity perspective argues that medicine should not only preserve life, but also honor the quality of life and the value that that patient has. The third central argument in favor of is the relief of suffering. And this is pretty straightforward. It falls under the ethical doctrine of beneficence, calling healthcare providers to act in ways that promote the well-being of patients. How many times have you or I been in CCT where we have a patient come in incredibly sick on death's doorsteps or peri-arrest, and we tell each other, hey, this is going to be a soft code, right? In those moments, we're practicing this idea of relief of suffering, that allowing them to pass peacefully instead of compressions, pressors, fluids is more humane than just giving medications. So moving to the flip side of the argument, what are some of the arguments against physician-assisted suicide? So there are 5 main ones. So the first one we're going to talk about is this idea of the slippery slope. So the laws and regulations that come into play for physician-assisted suicide may start off very narrowly defined, but over time, the fear is that it will expand incrementally to include patients that are non-terminal, so like COPD patients, patients who have psychological illnesses, minors even with parental consent. And supporters of physician-assisted suicide will say, well, this is just all fear-based. Just because something might happen doesn't mean that it actually will. But if you look at countries like Netherlands and then Belgium, they already have euthanasia laws that are much more lax than the US, and they do allow for euthanasia of non-terminal illnesses such as COPD. They do allow it for psychological illnesses and even minors with parental consent. So the slippery slope notion is a real fear. The second argument against it is the idea that life is sacred. And this really is rooted in the religious traditions that we talked about in the historical context, that the main monotheistic religions believe that life is a gift from a divine source, and only that source has the authority to end that life. And like we talked about earlier, a lot of religions will say that moral or suffering is a form of dignity, faith, and character building. And so one should suffer to show that you have faith and character. The third argument against it is one that we all know, part of the Hippocratic Oath is do no harm. Those against physician-assisted suicide will say that physicians should never intentionally inflict harm on others, and that inaction is preferred over actions that may result in permanent or irreversible harm. They also are worried that if we begin to allow patients to undergo physician-assisted suicide, it might undermine the public trust of physicians, because they'll start to believe that maybe the doctors might give up on them, that we won't seek all possible avenues of care because now we have this other option for patients to pursue. The fourth argument, which is the one that is scariest to me, is the idea of coercion. And this can be overt, right? Threats, force, or intimidation to place patients to undergo medical aid in dying. But there can also be subtle coercion where terminally ill patients, elderly, disabled, mentally ill people are emotionally manipulated into choosing death by family members because they're seen as a burden. There are even institutional pressures. There have been cases, not in the United States, but in other countries, where individuals have chosen to end their life because of the large cost of the medications and treatment plans for their terminal illness. And so medical aid in dying was a cheaper option. So you can see that even institutional pressures can coerce someone to choose death. And lastly is the idea of palliative care. Right, we have palliative care. Why don't we just put everyone on hospice, these terminally ill patients, give them a bunch of medications, take their pain away, and then let them die in peace? But a lot of patients will say, this is not how I'd like to go. I would still like to have my mental faculties in place. Sometimes there's limits to how much medications we can give to help someone suffering during those end stages of their terminal illness. So with both sides having strong points, where do we land today in terms of what is legal in the United States and around the world? So in the United States, like I said before, it's called MAiD, Medical Aid in Dying. It was first legalized in 1994 with Oregon under the Death with Dignity Act. And by 2025, there are now 10 US states, and then the District of Columbia, all the dark green on the map, that allow for medical aid in dying. Other countries allow for euthanasia, which are much more lax. And in the US, it's much more restrictive and incredibly hard to apply and be approved for MAiD. So there are quite a few criteria. Patients have to be older than 18. They have to be a resident within a state that allows for MAiD. And then there have to be multiple physicians who diagnose and prognose the disease as being terminal within 6 months. And then the patient themselves have to have informed and show competency and provide multiple requests. So it's not just written requests to the physician, but also oral requests to a board of physicians. And after multiple rounds, they are finally approved for MAiD. And this can take from months all the way to some cases taking almost 2 years to be approved for the process. And since being implemented in the US, it's still a very, very low percentage of patients who actually undergo MAiD. In all of the US states that allow for MAiD, it just represents 0.2% of deaths in those states. And of the patients that undergo MAiD, when looking at their demographics, it's usually older individuals, white, well-educated, and those who have terminal illnesses, with the majority, around 90%, being cancer patients. And the American public, their perception on whether this should be allowed in terms of terminally ill patients having the right to pursue MAiD hasn't really changed since the 1990s. We sit around 65% of the American population believes that this should be a right for those to pursue MAiD. when looking at physician polls and where we all sit in terms of what we think about MAiD, you can see that physicians are much more willing to discuss and even refer to a MAiD program. The probably and generally very perceptive to doing so. But then on the far side of the screen, you can see that those serving as the attending that prescribes the medication or those that are consulting as the second MD falls pretty low. So even if a lot of us might think that MAiD is a good idea, we still have some reservations in terms of going through with it. In terms of the medications that are used, it's a concoction of medications that alter from state to state, country to country, but it usually involves some of these. It's usually a sedative, hypnotic, paralytic, and then a cardiotoxic medication, digoxin, potassium chloride in high doses, or even amitriptyline. And then now briefly around the world, there are currently 14 countries that have either some form of MAiD or have more lax euthanasia laws. So most of them are in Western Europe. And then in South America, it's only Colombia that has very specific euthanasia criteria. And then in Oceania, it's New Zealand and almost all of Australia. I know, weird. So wrap up with a quick case. And this is a case that happened in Canada. So this patient, 68-year-old male, terminally ill pancreatic cancer patient, he arrived to the ED via EMS, hypotensive, obtunded, hypoxic, and was being bagged. Family member came with EMS, and they do note that the patient did take end-of-life medication, but the family member was in distress, couldn't just sit back and watch as the patient became more confused, altered, unresponsive, and so they activated 911. Unfortunately, they brought no documentations to MOLS forms, DNR forms, or even the MAiD documentation to the hospital, and that patient had never been to that ED. And so you have nothing in your EMR to say this patient is a MAiD patient who should be allowed to go through their end-of-life medication. So we can skip the poll everywhere, but the question I want to ask you, would you pursue with resuscitation, given the presentation that you have in front of you? The family member, it wasn't a next, it was like a aunt.
As much as I hate it, like after you
Yeah, and that's what eventually, that's exactly what happened. Legally, if there's no advance directive, most DNR, there's no MAiD documentation, nothing that you can verify, you should err on the side of caution and undergo life-saving treatment. But what the physicians did in this case was some of them went into the resuscitation to help with resuscitation, but then others did rapid collateral gathering. So they tried to call the hospice center. They asked EMS to go back to see if they could find any documentation at the house. They called the hospital legal ethical committee. And after about an hour of resuscitation, they were able to get the documentations that proved that patient was a MAiD patient and then allowed the patient to pass peacefully. But you can see how this becomes super murky waters pretty quickly, especially in our line of care where we don't always have all the information available. So I think when I was reading through this case, the learning point was that if we don't have anything, intentionality matters, right? It's great knowing that the patient wanted end of life medication, but if we can't verify it, err on the side of caution, and then at the same time, try to find your verifying documents. And then the second question, which unrelated to the case, is after, the 20 so minutes we talked, where do you feel you're at in terms of MAiD? Do you feel like it should be allowed, should not be allowed? Should it just be allowed for terminally ill cancer patients? Murky waters, don't know. Okay, some allowed, cool. All right, so that's it. I'm gonna leave these quotes up here, but I just wanted to emphasize that this topic is ethically, legally complex. It's been shaped by thousands of years of historical events and religion. And only now in our lifetime, since the 1990s, is it starting to gain momentum. I think as physicians who often encounter extremely sick patients and the fact that our population is aging in the United States, we may find ourselves in positions to discuss MAiD and even begin to help the process of referring to MAiD. And I know that countries in Canada where MAiD is legal throughout all the territories, they actually have implemented MAiD education curriculums in the medical school. So we may start to see that in our medical school system as MAiD expands in the United States. A final food for thought, don't have to answer it, but just think, what does compassion look like to you at the end of life? That's it. It's my references. I am not as emotionally strong as Nat. I did not include pictures because else I would start crying. Just wanted to say thank you to everyone, the leadership. You guys have become my family throughout these past 4 years. Wouldn't have done it without you. So thank you.